Hello viewers, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today's discussion is on surgical aspects of amoebiasis. It is a protozoal infection of surgical importance in developing countries. In the end, please subscribe to our channel and give us a like if you find the discussion useful. Also, don't forget to press the bell icon below to get my videos regularly. Amoebiasis is caused by an intestinal protozoan, Entamoeba histolytica. The infection causes asymptomatic carrier state in the 90% of the affected individuals and invasive amoebiasis in rest 10%. The infection is transmitted via the fecal-oral route. Cyst-contaminated water and vegetables are main sources of human infection. The disease occurs due to poor hygiene and sanitation. Therefore, the people from the lower socioeconomic strata are more vulnerable. The invasive disease usually presents as an intestinal colitis, that is dysentery or diarrhea, or as extraintestinal disease, in which abscesses form most commonly in the liver and uncommonly in the lung and rarely in the brain. Amoebic liver abscess is the commonest extraintestinal manifestation. The genitourinary tract may become involved by direct extension of amoebiasis from the colon or by hematogenous spread of the infection. In endemic areas, it is much more common than pyogenic abscesses. Immunocompromised and alcoholics are more susceptible. Amoebic liver abscesses are age and gender dependent. Men of 30 to 60 years are most commonly infected. Amoebiasis is a sexually transmitted disease also. The organism invades the gut through cyst-contaminated food or water. In the small gut, the cysts develop into a large number of trophozoites. Trophozoites have a characteristic central nucleolus. The adherence of trophozoites to colonic epithelial cells is mediated by a galactose N-acetyl galactosamine adherence lectin. Cystine proteinases facilitate invasion and inflammation of the gut. The ingested cysts pass through the stomach and the small bowel unharmed and then transform into trophozoites in the colon. In the colonic submucosa, trophozoites form typical flask-shaped ulcers. The trophozoites multiply to form daughter cysts, which are passed in the feces as an infective form. Trophozoites may enter the liver via the portal blood. Occasionally, the trophozoites pass through the hepatic sinusoid into the systemic circulation and results in lung and brain abscesses. Trophozoites do not pass through lymphatics. Both trophozoites and cysts are found in the intestinal lumen, but only trophozoites invade a tissue. In the portal circulation, the trophozoites enter the interlobular veins of the liver. Here they multiply and cause focal infarction of hepatocytes and liquefactive necrosis through enzymatic cellular hydrolysis. Necrosed areas coalesce to form abscess cavity. The hepatic necrosis does not cross Gleason capsule because it is resistant to hydrolysis by the amoebae. Hence, amoebic abscesses tend to abut the liver capsule. A chronic liver abscess may ultimately develop a fibrous capsule and may even calcify. Before the stage of macroscopic abscess formation, the condition is called amoebic hepatitis. In 80% of cases, the right lobe is involved. In 10%, the left lobe is involved, and in the remainder, both lobes are involved. The right lobe is more commonly involved because of the straighter course of superior mesenteric vein through the portal vein into the larger right lobe. Amoebic abscess is most commonly located in the superior anterior aspect of the right lobe of the liver near the diaphragm. Hence, pulmonary symptoms and chest complications may also occur. The pus of amoebic abscess is odorless and chocolate colored and has anchovy sauce appearance. It is a mixture of necrotic liver tissue debris and blood. It is bacteriologically sterile and has few or no cells. The pus in the abscess is sterile unless secondarily infected. A secondary bacterial infection may cause the pus to smell. Trophozoites may be found in the abscess cavity wall in some cases. Unless treated timely and adequately, the amoebic liver abscess may rupture either into the peritoneal cavity or the pleural cavity. In the large gut, most commonly in the cecum, a chronic amoebic infection may result in a granulomatous lesion called an amoeboma. The E. histolytica is resistant to complement-mediated lysis. IgA antibody provides acquired immunity to E. histolytica. The patient with amoebic liver abscess has insidious onset of non-specific symptoms such as upper abdominal pain, diarrhea, fever, cough, loss of appetite, night sweats, malaise, and weight loss. More specific symptoms such as right upper quadrant pain, right shoulder tip pain, hiccups, and a non-productive cough arise gradually. Suspicion should arise if there is a past history of bloody diarrhea or travel to an endemic area. Liver abscesses can occur without previous diarrhea. On examination, the patient looks toxic and anemic, may have upper abdominal rigidity, a tender hepatomegaly, tender and bulging intercostal spaces, local skin edema, a pleural effusion, and basal pneumonitis. Pulmonary features appear late in an acute case. Jaundice or ascites may be present but are uncommon. Rarely, rupture of the abscess into the peritoneal, pleural, or pericardial cavity may lead to an emergency presentation. A hepatobronchial fistula may develop with cough productive of large amounts of necrotic material or pus. Cecal involvement may mimic acute appendicitis. Patients may develop toxic megacolon. Virtually all patients have heme-positive stools. Painful genital punched-out ulcers with profuse discharge may develop. But even a dramatic presentation or complication carries a good prognosis if managed timely and appropriately. Cerebral involvement has been reported in less than 0.1% of patients. Complicated cases include large abscesses in the superior part of the right lobe. These may rupture into the pleural space, multiple abscess, and abscess in the left lobe, which may rupture into the pericardial space. Complete resolution of a liver abscess usually takes 6 months in 2/3 of patients, but 10% may have persistent lesions for a year. Once an abscess is identified in the liver through radiographic studies, the most important distinction to be made is between amoebic and pathogenic abscess. Pathogenic abscess typically occur in older population and patients usually have a history of bowel disease or a recent surgery. Amoeboma is a chronic amoebic granuloma arising in the large bowel. Its most common site is the cecum. It arises in cases of long-standing amoebic infection that has not been treated adequately, either without completion of a full course or from indiscriminate self-medication. This lesion can easily be mistaken for a carcinoma. It usually presents in a patient from an endemic area with poor health and intermittent fever. There is a mass in the right iliac fossa with a history of blood-stained diarrhea. When an amoeboma is suspected in a colonic mass, cancer should be excluded by colonoscopy and biopsy. Blood tests reveal a chronic infective process. There is leukocytosis, anemia, raised markers of inflammation such as erythrocyte sedimentation rate and C-reactive protein, and abnormal liver function tests, particularly elevated alkaline phosphatase and hypoalbuminemia. Patients typically have a mild to moderate leukocytosis without eosinophilia. The most common liver function test abnormality in amoebic abscess is an elevated PT-INR. A stool examination reveals amoebic colitis. It shows a positive heme test, a paucity of neutrophils, and amoebic cysts or trophozoites. The definitive diagnosis of amoebic colitis is made by the demonstration of hematophagous trophozoites of E. histolytica in fresh stool specimen. Trichrome-stained preparations of fresh stool and concentrates for cysts or trophozoites confirms the diagnosis in 75 to 95% of cases. Finding trophozoites in a biopsy of a colonic lesion confirms the diagnosis of amoeboma, but trophozoites are not seen in liver aspirates because they are found in the abscess capsule and not in the aspirated pus. The microscopic diagnosis of E. histolytica can be made only by the detection of entamoeba trophozoites that have ingested erythrocytes, because the cysts of E. histolytica cannot be distinguished microscopically from its other species. Enzyme immunoassay for the gal-NAC lectin of E. histolytica and multiplex PCR of a stool for E. histolytica are more sensitive and specific tests of a stool. Diagnostic aspiration is of limited value because it only shows the typical color of the pus, which is sterile and odorless unless secondarily infected. The most useful laboratory method is the measurement of circulating anti-amoebic antibodies, which are present in 90% to 95% of patients, because more than 70% of patients with amoebic liver abscess do not have detectable amoebae in their stool. Serological tests are more specific than parasitologic diagnosis for invasive amoebiasis. Examples are complement fixation test, enzyme immunoassays, indirect heme agglutination test, indirect immunofluorescence test, ELISA, and agar gel diffusion assays. ELISA and agar gel diffusion assays are positive in more than 90% of cases with amoebic colitis, amoeboma, or liver abscess. For 10% negative results, testing should be repeated within a week. In non-endemic regions, indirect heme agglutination test has a very high sensitivity in acute amoebic liver abscess. In endemic areas, counter-immunoelectrophoresis is more useful for detecting acute infection. Antigen detection kits to detect the E. histolytica lectin antigen in the serum and liver abscess pus also have been evaluated in endemic areas. These kits have been shown to have high sensitivity. Serological tests usually revert to negative within 6 to 12 months. The indirect heme agglutination test is difficult to interpret because it may remain positive for as long as 10 years. Serological tests are useful in assessing the risk of invasive amoebiasis in asymptomatic cyst-passing individuals in non-endemic areas. An indirect heme agglutination test was used extensively in the past. It has a sensitivity of 90%. This test has largely been replaced by enzyme immunoassay, which has a reported sensitivity of 99% and a specificity higher than 90% in patients with hepatic abscess. Before starting glucocorticoid therapy in patients with ulcerative colitis, serological tests should be performed to prevent the development of severe colitis or toxic megacolon owing to unsuspected amoebiasis. Loop-mediated isothermal amplification or LAMP assay is a simple, specific, rapid and low-cost alternative for detection of E. histolytica DNA in amoebic liver abscess pus sample. LAMP is DNA amplification method under isothermal conditions. It is a low-cost point-of-care testing tool in developing countries. Routine hematologic and biochemical tests usually are not very helpful in the diagnosis of invasive amoebiasis. Leukocytosis is found in about 3/4 of amoebic liver abscess patients, but mostly in acute setting or if there is some secondary complication. Amoebiasis does not elicit eosinophilia and anemia, but if present, these are usually pre-existing. Liver enzymes are normal or minimally elevated. The alkaline phosphatase is most often raised and may remain elevated for months. Rigid sigmoidoscopy is prudent in presence of bloody mucoid diarrhea if an amoebic infection is suspected, because most amoebic ulcers occur in the rectosigmoid region and are within the reach of a sigmoidoscope. Flash sepid or collar stud ulcers may be located and can be biopsied or scrapings taken along with mucus for immediate microscopic examination through rigid sigmoidoscopy. The finding of trophozoites distinguishes the condition from ulcerative colitis. Ultrasound is a very accurate modality for diagnosing as well as treating an amoebic liver abscess. The abscess cavity is seen as a hypoechoic or anechoic lesion with ill-defined borders. Internal echoes suggest necrotic material or debris. It is the investigation of choice for amoebic liver abscess. In doubtful cases, a computed tomography scan may be done. A plain radiograph and CT scan may show a raised right hemidiaphragm, a pleural effusion, and evidence of pneumonitis. On barium enema, an apple-core appearance may arouse suspicion of a carcinoma. In these cases, a colonoscopy with biopsy is essential to make a distinction from a carcinoma. In doubtful cases, full medical treatment is given for 3 to 4 weeks and the colonoscopy is repeated. Amoebic masses regress completely on a full course of drug therapy, but a carcinoma does not. It must be remembered that an amoeboma and a carcinoma can coexist in endemic areas. Radionuclide gallium scanning or technetium 99 liver scans are helpful in differentiating pyogenic from amoebic liver abscesses. Because the amoebic abscesses do not contain leukocytes and therefore do not show up on these scans. Metronidazole and tinidazole are the effective drugs for medical treatment of amoebiasis. Metronidazole is the drug of choice. Metronidazole 800 mg orally 3 times daily for 7 to 10 days is curative in 95% of patients. All treatment regimens should include a 10-day course of a luminal amebicide agent such as diloxanid furuate, iodoquinol or paromomycin to eradicate cysts and prevent carrier state and further transmission. The above should be the first line of treatment in the non-emergency cases, and aspiration and surgery are reserved for an imminent rupture and complications such as rupture into the pleural, pericardial, or peritoneal cavities. But luminal agents are not effective against hepatic disease. Wide-bore needle aspiration is done when there is rupture of an abscess is expected. It should be carried out along with the drug treatment in a patient with a large abscess. For large and multiple abscesses, repeated aspirations along with drug treatment may be needed. For secondary infection, other appropriate drug is added. Aspirating an abscess in the left lobe should be cautious because of its proximity to the pericardium. For severe hemorrhage and toxic megacolon, resuscitation, intensive supportive therapy followed by bowel exteriorization such as subtotal colectomy with terminal ileostomy and closure of the rectal stump should be done. If an amoeboma has not regressed after vigorous medical treatment, colonic resection should be done, particularly if cancer cannot be excluded.